Hi, it's Matthew Links, medical oncologist from Alice Springs Hospital, and welcome to this video in our series 5 Minutes Remote Cancer Care on IV chemotherapy. It's focused on standard cytotoxics rather than immunotherapy or targeted agents, and some of the issues are a little different with oral agents. It's aimed at health workers in remote communities caring for patients receiving one of these drugs. I'd like to start by acknowledging the Aranda people on whose lands I live and work, and elders past, present and emerging from this community and all the remote communities who receive and give cancer care. Our learning objectives are listed on the screen and focus on pragmatic issues of explaining chemotherapy, managing toxicities, planning for febrile neutropenia, safe handling and dealing with unmet needs, all applied to a remote setting. So a key task is to communicate in a simple way what chemotherapy is, and we like the metaphor of cancer being like a weed, for example, buffel grass. Chemotherapy is like spraying weed killer. It poisons the cancer, but it gets into your normal body as well, which is why you get side effects. And it works because your body, like country, bounces back. Now, it's easy to remember the conventional anti-proliferative side effects, chemotherapy, alopecia, cytopenias and mucositis, and some of the more modern drugs may not cause significant alopecia or are mildly metagenic. And there are standard pathways preventing and managing each of these. More difficult are the toxicities in other organs such as neuropathy, cardiomyopathy, which are drug specific, and often these are managed by monitoring dose modification and support. A significant issue in practice is fatigue and chemo brain. These are often the limiting side effects when other side effects get managed or prevented. Exercise is good at minimising fatigue, but it's hard to achieve. And chemo brain is usually mild, but it can impact on daily life. Mobilising community support is important for coping with each of these side effects. Now, febrile neutropenia is a difficult issue in remote communities. It's an oncological emergency, but part of the problem is you don't know if they're neutropenic and they may not be febrile if they're septic. If they do deteriorate, it might take a while before you can get them to a centre with an ICU. And for these reasons, it's best to work up anyone with suspected sepsis after chemotherapy as a suspected febrile neutropenia. Treat them and repatriate them. It's worth thinking through how such an event would be managed, making sure there's supplies of antibiotics on hand and having an agreed strategy. The management follows standard sepsis lines of stabilisation, assessment, culture and early antibiotics, with a goal of antibiotics within 60 minutes prior to transfer or 30 minutes if they're unstable. A difference from most protocols in other centres is the use of vancomycin in view of the high prevalence of staph. A good toxicity assessment is about a good history focused on the functional impact. So for mucositis, it's the impact on eating. And for diarrhoea, it might be about the number of loose stools over baseline or the presence of incontinence, but also importantly about social functioning. The second thing is understanding what went wrong with the management plan. There should always have been a plan for prophylaxis and early treatment. So if symptoms are breaking through, what went wrong? Was prophylaxis given? Was rescue given? Was it too little, too late? Was understanding the barrier, or was it side effects? Identifying a better strategy is the key to improvement. Safe handling of hazardous drugs is an important issue, and there's a need to protect patients, family and staff. Particular challenges in remote communities include housing, access to toilets and overcrowding. The trick is to be sensible and not get paranoid. You don't need a hazmat suit and you can hug your grandchildren. The issue is with body fluid exposure, toilets, sexual contact and disposal of contaminated items such as continence pads, etc. So it's worth considering how this issue applies to this patient, and for further information consult the FAQ guide. If it's not possible to manage these issues in the patient's current environment, the question comes up if there's an alternative. Can they move to another family member's place, or do they need to come into town? As with all cancer patients, a major role in primary care is providing ongoing support and identifying any unmet physical, psychosocial and cultural needs. This is an invaluable feedback mechanism. identifying these needs, mobilising supports available in primary care, and communicating information back about unmet needs to the oncology service is very helpful. There's a lot of additional information available. Particularly useful is the EverQ website with specific information on individual protocols and a section on the management of side effects. Thanks to all those who've taken time to review this site, and please email if there's any feedback or leave a comment on the YouTube channel. Looking after cancer patients in remote communities is complex and requires sharing care, working more effectively together. There's a lot to learn. Thank you for your efforts.